The aim of this short video is to introduce the Theatre 38 environment, workflow and common pitfalls to avoid. Working in Theatre 38 is a little different from other lists here at the RVI. It is different because of the type of work, a mixture of diagnostic/blended therapeutic work on otherwise well patients, urgent work to treat and protect aneurysmal patients, which range from nursing level 1, GCS 15, otherwise well patients, through to those with severe subarachnoid hemorrhage who are critically unwell and require transfer ventilated to and from intensive care unit on Ward 18. There are also time-critical emergencies in the form of mechanical thrombectomy for vascular occlusive stroke patients. We will talk more about this later. It is also different in the way the workflow is managed. Just like a normal day, pick up a list, collect the emergency phone, touch base with the theatre staff and see the elective patients on the ward. Check your machines and prepare a plan for GA, keeping in mind standard neuroprotective anaesthetic principles and the SOP which is available on the intranet. As the patient arrives down the corridor, they usually come on a trolley and enter through the double doors. We will pause here for a second because these are some important numbers that you may wish to jot down so that you have a record should you need to get in touch with any of these people at a moment's notice. Always be aware who your backup is, whether that be a supervisor, an available consultant, or the pink or orange anaesthetist out of hours. As we enter the control room, you'll see some lead gowns on the left, and up on this shelf, in a charging cradle, the 48661 telephone. Please make sure that at the end of your shift, you return it to the cradle so that it's perfectly charged for the next person who picks it up. As we enter the theatre itself, you'll see there's a large space in front of the table. This is where the interventional radiologist will stand along with their assistant, their equipment, and a runner gathering various bits of kit. At the bottom of the bed, to the right, the foot end of the bed, is where the radiographer stands. They are the one who has control of the bed itself. They would normally warn you when they're moving in and out to check your lines and your tubings, and you should always check beforehand, but do just make sure that you know when the table is moving. Around this side is where the anaesthetic computer, a lead shield, and the anaesthetic machine live. As you can see, the location of the anaesthetic machine and the operating table itself are quite distant from each other. It's also worth bearing in mind that the patient is going to arrive on a trolley on the other side of the table to the anaesthetic machine. Make sure that there's a 5-metre tube because you need the stretch, not only to go from the anaesthetic machine over to the trolley for induction of anaesthesia, but also because when they're on the table, all lines, and including the tube, must be swept down the left-hand side of the patient before taking a right angle and going off towards the anaesthetic machine. Patients arrive through the double doors on a trolley. Most anaesthetists choose to induce on the trolley and then transfer to the table. The cases are minimally invasive and minimally stimulating. Remember principles of neuroanaesthesia, aiming for a quick wake-up to facilitate neurological monitoring in recovery. This aids diagnosis of complications should they arise. Avoid excess opiates and sedatives which may mask this. In emergency cases, for mechanical thrombectomy, you will normally hear first from either the stroke nurse or physician, or alternatively from the theatre staff. Time is critical, but as always, we proceed at the speed of safety. Do not rush, and remember, slow is smooth, and smooth is fast. We do not see mechanical thrombectomy patients before their arrival in theatre. A referral from the stroke team activates the theatre staff, Make a plan and gather help if required. Common pitfalls. Hemodynamics in acute stroke are often managed with GTN transdermal patches. These should be removed prior to induction of anaesthesia to avoid a precipitous drop in blood pressure. Patients arrive unfasted, with potential for unsafe swallow given the pathology involved. Plan for this accordingly on induction and extubation. Intraoperative drugs. The interventional radiologist may ask for IV antiplatelet drugs such as aspirin or eptifibatide, also known as integralin. These are locked away in the drug cupboard, reconstituted in saline and given as a slow infusion over 5 minutes. Heparin is used routinely in coiling cases along with ACT monitoring, but where the risk of rupture is high, be mindful of your immediate actions and protamine dosing should disaster strike. At the end of the case, the groin puncture is closed with instructions to watch for bleeding in recovery and the ward, and is usually well covered with local anaesthetic. Minimal analgesia is required.
I've included here the standard operating procedure for anaesthesia for mechanical thrombectomy. A lot of the things we've already spoken about, but this is a really helpful guide and something to keep you right if you're ever in doubt.
Lastly, interventional neuroradiology, including mechanical thrombectomy, is a potent and life-saving treatment, and our provision of this service continues to evolve. I trust you will find it a rewarding and interesting experience in your clinical practice. Thank you for listening.